In today's session, I'll be discussing again the important images. As I've highlighted in the previous session, images are extremely important for your exam. There were at least 20 odd image-based questions from surgery this year. Total number of questions from surgery in your FMGE exam were around 35, and around 20 to 25 were image-based questions. If we are to follow the same trend and the clinical trend, clinical images will assume a lot of importance. Today, I'll be discussing the images of general surgery, trauma, burns, plastic surgery. So all the general surgery topics, images I'll be discussing today. These are extremely important, and at least 4 to 5 questions can be expected from these images, which I'm going to show you. Now, the first image which I want to discuss in general surgery is the surgical safety checklist. I've covered this many times previously, the surgical safety checklist. And in the surgical safety checklist, you should know that there are 3 main key aspects of the surgical safety checklist. This is to improve patient safety. You have the sign-in phase, you have the time-out phase, and you have the sign-out phase. Right? These are the 3 phases which are there. And the important thing in each phase, sign-in is before induction of anesthesia. And in the sign-in phase, we confirm the identity of the patient. We check the site which is to be operated so that we don't operate on the wrong side. And we look for the consent. The consent, mind you, I hope you people are also making notes. Keep on making notes. Not everything is written on the slides. The consent is always a written consent. It is always a written consent, not a verbal consent. The second phase is before skin incision. This is the time-out phase before we start surgery. And the 2 key things from the FMG exam point of view which you need to remember, that antibiotic prophylaxis is checked in this phase. Antibiotic prophylaxis is checked in this phase, and also the surgeon tells the entire team what surgery is he going to perform. The sign out phase is the final phase when the surgery is about to get over. And again, very important, the nurse counts the equipment and the gauze pieces to make sure that nothing has been left inside. So I've highlighted the 3 key phases of surgical safety checklist and the important points in each phase which you need to know for the exam. All of you should be able to identify IV lines. Very, very, very important. So you should know that 14 gauge is orange, gray is 16, green is 18, pink is 20, blue is 22, yellow is 24. This might sound boring, but this is a very, very important question. Every year, this is asked, har saal pucha jata hai. Now, 14 gauge is the widest bore, whereas yellow or 24 is the narrowest bore. And jitta wide hoga, the wider it is, the easier or the faster the flow rate. You can easily give fluids through that. And the narrower the cannula, the slower the flow rate. You should know that the most common, there is no mnemonic, please. There's no mnemonic for this. This is easy to remember. It's a one-time effort. If you revise it, you can easily remember it. Please don't fall in the prey of mnemonics for these IV lines. You can easily remember it, okay? You should know that the most common complication of IV lines, superficial thrombophlebitis, is the most common complication of IV lines. You can see here that there is a cord-like swelling which develops starting from the IV line. This is superficial thrombophlebitis. The next thing which is also commonly asked in the FMG exam, the various surgical positions. You all know about lithotomy position. Lithotomy position is commonly used for hemorrhoid surgery, for fissure surgery, for TURP. You know that TURP is transurethral resection of prostate. And you should know, this has also been asked in the exam, that common peroneal nerve injury is quite common if the legs are not supported properly. So if you don't support the legs properly, then that can give rise to common peroneal nerve injury. The lateral or the kidney position, this is used for thoracotomy procedures and also for renal procedures. Prone position is used for spinal surgery. This has also been asked in the exam. Prone position is used for spinal surgery. The supine position is the most common position where the patient is lying straight. That is the most common surgical position. For most of the abdominal procedures, supine position is done. You also have the jackknife position. This is the jackknife position where the patient is in the knee elbow position. And very important question which has been asked in the exam, that this is not used now. Jackknife position is not used because of positional asphyxia. So you should know that we no longer use jackknife position. This image or this position has also been asked. This is Fowler's or sitting position. This is best for CNS surgeries. For CNS surgeries, especially the posterior fossa surgeries. The drawback of this position is that there is increased risk of air embolism. The good thing about this position is better exposure, and it gives you a bloodless field. Better exposure, bloodless field, but the drawback is increased risk of air embolism. You should know that if the OT table, the head end and the foot end are at the same level, that is known as the neutral position of the OT table. If the head end and foot end are at the same level, that is the neutral position. If the head end is raised and the foot end is low, that is known as reverse Trendelenburg position. Head end raised, foot end low is reverse Trendelenburg position. And very importantly, this is used for lap cholecystectomy. This has been asked in the exam. Lap cholecystectomy, reverse Trendelenburg, and right side up is used. Trendelenburg position, where the foot end is raised and the head end is low, is used for pelvic surgery. A super important question for your exam is regarding energy sources, and these two images have been asked multiple times in the FMGE exam. You have a bipolar cautery and you have a monopolar cautery. You should be able to identify both the images. Bipolar cautery is like prongs, right? They're like prongs, chimte jaise lagte hain. Whereas monopolar cautery is like a pencil or a pen. So that's how you differentiate between the two. Monopolar cautery, the one which is like a pencil, has two buttons. You have a yellow and a blue button. Yellow is for cutting, blue is for coagulation. Bipolar cautery, there are two, it's like prongs, so there are two paddles here. It is safe to use close to vital nerves and end arteries. Extremely important question. Safe to use close to vital nerves and end arteries. So the surgeries which can be done using bipolar cautery are ear lobule surgery, penile surgery, thyroid and parotid surgery. Whenever we are using a monopolar cautery, we need to use a cautery pad. Some of you must have seen this cautery pad in the theater. Those who've seen this in the theater, give me a thumbs up on the chat box. So this is a cautery pad which we put on the thigh or the calf of the patient, and it should have a wide area of contact. Now, mind you, this is for monopolar cautery, not for bipolar. You don't need this. Also, if you use a small pad which is not fitting properly, that can give rise to burns at the site of the cautery pad. So good, a lot of you have seen this cautery pad. Mark on the surface of the skin. There is no mark on the surface of the skin. So when there is no mark on the surface of the skin, will this be cosmetically better or cosmetically poor? Answer in the chat box, please. If there is no mark on the skin, will this be cosmetically better or cosmetically poor? Cosmetically better. Excellent. This is cosmetically better. So this is a cosmetic suturing technique. And the question which has been asked in your exam, that 3-0 monocryl, that is the suture material used for subcuticular suturing. 3-0 monocryl. Another important image from Bailey is that this is regarding skin suturing. If the depth of the wound is X centimeters, then the distance between two sutures should be 2x. Distance between two sutures is 2 times the depth. Whereas the bite on each side we take a bite of X, but the distance between two sutures is 2x. So this is another image from Bailey which you should know about. This has also been asked in the FMGE exam. A needle has three parts. You have the pointed end, you have the body, and you have the swaged end. It is not swag, it is swaged. This is what was asked in the exam, swaged end. The swaged end is where the thread is attached. Where the thread is attached, that is the swaged end. And you can have two types of needles. You can have a cutting and you can have a round body needle. Cutting needle has a triangular cross section and it is used for tough structures like the skin and the sheath. Whereas the round body needles are used for delicate structures like CBD, that is common bile duct, bowel, and blood vessels and bladder. Another question, where do we hold the needle? You can see it is held 1/3 from the swaged end and 2/3 from the pointed end. 1/3 from the swaged end, 2/3 from the pointed end. Been asked in your exam, circular stapler and linear stapler. Circular stapler, you should be able to identify these two images. Circular stapler is used for hemorrhoid surgery and for low anterior resection for rectal cancer or sigmoid cancer surgery. Whereas a linear stapler is used for sleeve gastrectomy, which is a bariatric surgery procedure, and for Zenker's diverticulum as well, for diverticulectomy. Again, very important, staplers. Now, the causes of postoperative fever in FMG, you can get clinical scenarios from this. On the first postoperative day, the most common cause is atelectasis. Atelectasis is collapse of the alveoli. And to correct the collapse of the alveoli, we use an incentive spirometer. This image was asked in your exam. Very important. How many of you have seen an incentive spirometer in the ward and the patient lifting these balls up? So incentive spirometer is used for chest physiotherapy, and this can prevent atelectasis. Good, a lot of you have seen it. I'm happy about that. Good. Postoperative day 2 or 3, the most common cause of hospital-acquired infection is urinary tract infection. You can develop pneumonia, superficial thrombophlebitis, the image I've already shown to you. Day 4, day 5, patient can develop SSI. SSI is surgical site infection. The definition of surgical site infection has also been asked. It is wound infection which develops within 30 days of surgery. It is wound infection which develops within 30 days of surgery, or if an implant is used, 1 year of surgery. So you should know the definition of surgical site infection as well. DVT is deep venous thrombosis, and to prevent DVT, we can use pneumatic anti-DVT stockings. The image of pneumatic anti-DVT stockings has also been asked multiple times. These stockings are connected to a pump, and this pump pushes in air. The stocking inflates and it prevents stasis of blood. It prevents stasis of blood. POD means post-operative day. Ranjita is asking, what is POD? POD means post-operative day. After surgery, which day? That will be post-operative day. This one is an anti-shock garment. This is anti-shock garment. Anti-shock garment is used in patients with hypovolemic shock. It is used in patients with hypovolemic shock, those who are bleeding. Supposing in the battlefield, there is a patient who's bleeding, you can use an anti-shock garment that is going to push blood from the lower limbs to the heart, and that helps in maintaining the cardiac output and the systolic blood pressure. Helps in maintaining the cardiac output and the systolic blood pressure. This is a pigtail catheter. I've already written here. Pigtail catheters are used to drain intra-abdominal collections. Pigtail catheters are used to drain intra-abdominal collections. Karan is absolutely right. He's saying low molecular weight heparin is better for prevention, or the mechanical technique. Low molecular weight heparin is much, much better than the mechanical technique. Low molecular weight heparin is much better than the mechanical technique. This is burst abdomen. Burst abdomen is when the rectus sheath wound opens up. That is burst abdomen, when the rectus sheath wound opens up. And this occurs around day 6. And you get a salmon fluid sign. Salmon fluid sign is when pinkish fluid comes out of the wound. That is a sign of burst abdomen. When a burst abdomen develops, the emergency management is urobag laparostomy. This is the emergency management. The rectus sheath which is opened up, we will put a urobag on top of that and we'll cover up the wound. That is known as urobag laparostomy. That is the emergency management. Yes, pigtail can be used for pleural drainage as well. Pigtail can be used for pleural drainage as well. So urobag laparostomy is the temporary or the emergency management for a patient with burst abdomen. You should know the names of 2 scores, asepsis wound score. You don't need to know the details for the FMGE exam. You should know the asepsis wound score is used for wound infections or SSI. This is the asepsis wound score. And this one is the Southampton wound score. This one is the Southampton wound score. These are the 2 scores which are used for wound infections, Southampton and the asepsis score. Very important in the age of corona. This is very important. VAC can also be used, correct? I'll tell you about VAC as well. But more importantly for your exam, please remember this, the 5 moments of hand hygiene. The 5 moments of hand hygiene when you should use a sanitizer. So you should use a sanitizer before touching the patient, after touching the patient, if you touch the patient's surroundings, if you're exposed to the body fluids of the patients, and before carrying out any procedure. These are the 5 moments of hand hygiene where a sanitizer, alcohol-based sanitizer should be used. But an important question, the places where soap and water are to be used, once you've visited the toilet, sanitizer alone is not enough. You should wash your hands with soap and water. And if the hands are visibly soiled. This question was asked in one of the recent exams. You should know the 5 moments of hand hygiene. They're extremely important for the exam. These are the various steps of hand washing. The steps are highlighted in the image. You will get the PDF. These steps have not been asked, the details have not been asked in the FMG exam, but they've been asked in another exam. There's no harm in knowing the steps of hand washing. And the question which you should know, that hand washing is the most important, hand washing is the most important factor to reduce wound infection. Hand hygiene or hand washing is the most important factor to reduce wound infection. These are the 3 sites where even if you wash your hands, contamination can be missed behind. Even if you wash your hands properly, contamination can be missed. That is the thumb, interdigital area, and the tips. Thumb, interdigital area, and the tips. These are the places where contamination can still be missed. This one is known as a bear hugger, and this bear hugger blows hot air over the patient. This is to prevent hypothermia during surgery. If there is hypothermia, there can be a lot of complications, including increased wound infections, and a bear hugger is used to prevent hypothermia during surgery. Extremely important for the exam is a Ryle's tube. It's as important as an IV line. A lot of questions over the last 2 or 3 years have been asked regarding Ryle's tube. Ryle's tube or nasogastric tubes, you should be able to identify them. The best position to put in a Ryle's tube is the sitting position with the neck slightly flexed. Sitting position with the neck slightly flexed. You should know that the length of the Ryle's tube, how to measure the length of the Ryle's tube from the nose to the ear and ear to the xiphisternum. Nose to the ear and ear to the xiphisternum. That is the best position, or that is the best way to measure the length of the Ryle's tube which is to be inserted. I'm sure a lot of you must have seen Ryle's tube being inserted. You should know all the potential questions pertaining to Ryle's tube. I've just told you some of the important questions. This one is a PICC line, peripherally inserted central catheter. Peripherally inserted central catheter, that means you will insert it like an IV line, but the tip is lying in a central vein. Tip is lying in a central vein. This is a PICC line. PICC line can be used to deliver nutrition. PICC lines can be used for chemotherapy. PICC lines can also be used to deliver antibiotics for a long time. This one is a central vein. You can see this is a central line or a central venous insertion. And central line, the question which was asked last year in the FMGE exam, the most commonly used vein is the internal jugular vein. The most commonly used vein is the internal jugular vein. The highest risk of pneumothorax is when you insert it in the subclavian vein, and the least risk of infection is also with subclavian. Please remember, questions from central lines are extremely important. You should know about a central line and these simple questions which I've told you. This milkish fluid, which you must have seen, has anyone seen this PPN solution? A bag of milkish fluid which is going into the IV line of a surgical patient or in the ICU. Has anyone seen this? This is total parenteral nutrition, TPN, and 1 to 2 liters is given in 1 day. I'm glad that a lot of you have seen this. Good. Another very important question which was asked last year in the exam and in various other exams, this has been asked multiple times, is Q-SOFA. Q-SOFA is quick sequential organ failure assessment score. Quick sequential organ failure assessment score is Q-SOFA, and this includes 3 parameters: hypotension less than 100, altered mental status, and tachypnea more than 22. Hypotension less than 100, altered mental status, and tachypnea more than 22. And if you have a score of 2 or more than 2, then that indicates sepsis, and that indicates a poor outcome. Indicates sepsis and indicates a poor outcome. Sepsis 3.0 guidelines, you should know the important points. Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. That is the definition of sepsis. Septic shock is when the BP is not increasing just with fluids and you need vasopressors as well. Q-SOFA does not include the heart rate. Heart rate is not there in Q-SOFA. It is for SIRS, you have the pulse rate more than 90, not for Q-SOFA. How does Q-SOFA work? Q-SOFA is just a score. So if the patient is meeting these criteria and there is a known foci of infection, you will call it sepsis then. So before I move on to the images for trauma, I hope all of you are solving MCQs regularly. In my previous sessions also, I've told you that you should be solving at least 50 to 60 MCQs on a daily basis these days. Marrow already has made a Q bank for some subjects, specifically for FMGE. You can access it through your Marrow plans if you have them. Otherwise, there are a lot of free question modules available as well in the Q bank, which you can appear for. Practice clinical questions. Make sure that you've done last 3 years FMG questions and last 3 years NEET exam questions. My request also is to solve UPSC questions. You can find them on my YouTube channel as well, because a lot of UPSC based topics are asked directly in your FMG exam also. Now, talking about trauma, you should know about the trimodal distribution of mortality. Trimodal distribution means there are 3 spikes. First spike of death occurs at impact, and this is mainly due to severe head injury. Unfortunately, we cannot save these patients. You people must have heard that there were a group of 17 gynecologists who were going to Goa last month. Their bus met with an accident and all of them unfortunately passed away. Most of them passed away due to head injuries, and severe head injuries, it is very difficult to save patients. Within the first hour, the causes of death are airway obstruction, tracheobronchial injury, pneumothorax, circulatory arrest, hemothorax, and tamponade. And if the patient can be brought to the hospital within the first hour, we can prevent mortality. And that is why the first hour following trauma is the golden hour following trauma. The first hour following trauma is the golden hour following trauma. This question has also been asked in the exam. Can you tell me what is the golden period for a wound? There are two separate questions. What is the golden hour is the first hour following trauma. But can you tell me what is the golden period for a wound? Can you answer that in the chat box, please? 6 hours. Excellent. 6 hours is the correct answer. Very good. 6 hours is the correct answer. The third spike of mortality is due to delayed head injury and sepsis. You should know that cervical spine is very important. Cervical spine management is very important in a trauma patient, and we follow the nexus criteria for the cervical spine. We follow the nexus criteria. The nexus criteria, the mnemonic for the nexus criteria, N is for neurological deficit, E is for alcohol intoxication, X is for extreme distracting neck injuries, U is unable to provide history or unable to speak, and S is spinal tenderness. This you need to remember. If any is present, if any sign is present, we will image the cervical spine. Even if you have a single of these signs present, you have to image the cervical spine, and that is important for the exam. This one is a video laryngoscope. Video laryngoscopes are used for intubation. You know, intubation is mainly done through the orotracheal route, and this is a video laryngoscope which can facilitate intubation in trauma patients. Supposing you cannot intubate a patient, supposing we cannot intubate, then we need to make an emergency airway. And this emergency airway has been asked multiple times in the exam. The emergency airway which we use is needle cricothyroidotomy. This has been asked many, many times in the FMGE exam. This is if you cannot put in an endotracheal tube. This is how we will get an emergency airway. The definitive management, if you cannot put in a tube, the definitive management is to put in a tracheostomy, right? Is to make a tracheostomy. First, we do a needle cricothyroidotomy, then tracheostomy is the definitive management if a tube cannot be inserted. All trauma patients, you should put in wide bore IV lines. But if you cannot put in an IV line, supposing it's not possible for you to put in an IV line, then you can even do intraosseous infusion. You should be able to identify this image. Intraosseous infusion, you puncture the bone just below the tibial tuberosity, and you can give fluids, you can give blood, you can give drugs. This is also one of the emergency managements if you cannot put in an IV line. Somebody just asked about fluids to be given. There is an update. You should give 1 liter of crystalloid in a trauma patient initially instead of 2 liters. So crystalloids are given initially and 1 liter is given instead of 2 liters initially. This is another update which you should know. So somebody is asking what to do if the patient's mouth is full of secretions and fluids. What to do first? You first suction it out and then try to intubate. You suction it out and then try to intubate. If crystalloids don't work, you can even use colloids and blood products. But again, a question which has been asked in the exam is a log roll. Log roll is a technique done to examine the back of a trauma patient. It is a technique done to examine the back of a trauma patient. And the question which has been asked, minimum 4 people are used to carry out an effective log roll. Super important for your exam is Glasgow coma score, and there are certain changes which have occurred in the Glasgow coma score. All of you should be able to memorize the Glasgow coma score and questions based on it first. If the patient has osteomyelitis, of course, you're not going to do interosseous infusion. That's a ridiculous question. And if there is a limb defect, yes, 5 people are required. First crystalloids, then colloids. You don't use colloids first. You don't give blood products straight away. First, give crystalloids. Now, coming to the Glasgow coma score, all of you should know about the Glasgow coma score. The motor response, 1 is none, 2 is extension, 3 is abnormal flexion, 4 is when the patient withdraws away from pain, 5 is when the patient localizes pain, and 6 is when the patient is obeying commands. Always remember, follow or record the highest possible motor response. Please write this line down. Always record the highest motor response. This question has been asked in clinical scenarios. Verbal response, 5 is when the patient is oriented, 4 is when the patient is confused, 3 is when the patient is using inappropriate words, 2 is when the patient is making incomprehensible sounds, and 1 is when the patient is not speaking at all. Eye opening, 4 is spontaneous, 3 is to speech, 2 is to pressure, and 1 is when there's no eye opening. One update is the GCS P score. B score is the pupil reactivity score, that is the P score, and it is to be subtracted from GCS. So this is one update. If both the pupils, look here please, if both the pupils are unreactive to light, then you will subtract 2 from the GCS. If one pupil is unreactive to light, you will subtract 1. If neither pupil is unreactive, subtract 0. This is an important update for your exam. Somebody has also asked me, how do we calculate the GCS score for an intubated patient? So earlier intubated patient, it was written as VT and VT was given a score of 1. Earlier intubated patients, it was written as VT and it was given a score of 1. But now we write it as VNT. NT is non-testable. Now we write it as NT or non-testable. That's correct. Excellent. VT is not 0. VT initially was given a score of 1. Now we write it as NT or non-testable. So if you have a patient with blunt trauma abdomen, if the patient is hemodynamically stable, the first investigation always is fast, but in a stable patient, the investigation of choice is CECT, that is contrast enhanced CT scan. For an unstable patient, the investigation of choice in both the situations is fast. What is fast? It has been asked many, many times in your exam. Fast is focused assessment sonogram in trauma. You should know the full form, focused assessment sonogram in trauma, and in FAST, the probe is kept at 4 places. First is the epigastrium, second is the right hypochondrium, third is the left hypochondrium, fourth is the hypogastrium. You should know the order in which the probe is kept in FAST. You should know the full form of FAST as well. It is important. Another update is eFast. eFast is extended fast. That is, you keep it in 4 places, plus you assess the thoracic cavity. So in total, the probe is kept at 6 places. In total, the probe is kept at 6 places. So somebody is asking if veins are collapsed and you cannot, and you have a patient with osteomyelitis, if the veins are collapsed, you will put in a central line and you give fluids through the central line, and you can even give antibiotics through that central line. Shubham, of course, for probe placement in EFAS, first you place the 4 probes here, then you do the thoracic cavity. The two additional places for EFAST are the thoracic cavity, right and left thoracic cavity. So once you assess the thorax, that becomes EFAST or extended fast. These are the grades of splenic trauma. You need to know the grades of splenic trauma. This you need to. Which are the two thoracic positions. Thorax, you keep it to look for the pleural space. There is no fixed position. You will keep it along the chest wall to assess the pleura on both the sides. That becomes EFAS. There's no fixed position where you keep it. So you should know the grades of splenic trauma. These are important for the exam. I only want you to remember the grades of splenic trauma, not the other organs. This is the management of splenic trauma. If you have a grade 1, grade 2 injury, the patient is usually stable. The investigation of choice is CECT, and these patients are managed conservatively. Conservative management doesn't mean you dump them on the bed and forget about them. You have to monitor the vitals, monitor the hematocrit. If the grade of injury is increasing, you can angioembolize the patient. If that fails, you need to carry out surgery. But if you're doing surgery for a grade 1, grade 2 injury, we do splenic preservation surgery. For grade 4, grade 5, we will do splenectomy. We remove the entire spleen. There was a question from zones of retroperitoneal trauma in last year's FMG exam. In the last FMG exam, you should know about this. Zone 1 includes the major vessels, and we should explore all penetrating injuries to zone 1. All penetrating injuries to zone 1 should be explored, and zone 1 has maximum mortality, Zone 2 includes the kidney and the ureter and the renal vessels. You should explore patients who have a vascular injury or those who are unstable. Zone 3 is the most commonly injured zone. The pelvic area, majority patients can be managed conservatively here. You should know these zones. This was asked in the last FMG exam. Flail chest is important. The definition of flail chest is fracture of 2 or more consecutive ribs at 2 or more places. That is the definition of flail chest. And in these two images which has been shown, patient A has a flail chest. Patient A is the one who has a flail chest. B does not have a flail chest because there are 2 or more than 2 fractures at 2 or more than 2 consecutive ribs in patient A. The initial management is pain control and oxygen. And if the respiratory rate is more than 20 or the PO2 is less than 60, then IPPV is done. Can you write the full form of IPPV? It has been asked in your exam. Can you write down the full form of IPPV in the chat box, please? This is a very important X-ray. Correct. Intermittent positive pressure ventilation. Excellent, guys. Intermittent positive pressure ventilation. Very good. This is tension pneumothorax. You can see here that there is a blackout here. There is pneumothorax here. In patients are going to have tachypnea, hypotension, and raised JVP. And there will be a hyper-resonant percussion note on the side of pneumothorax. This you should know. Hyper-resonant percussion note. Very important update. This has been asked multiple times. In EFAST, there are 3 signs for tension pneumothorax. Seashore, barcode, and stratosphere. Seashore, barcode, and stratosphere signs. So you should know about these signs. And you should also know that now the needle, the emergency management is needle decompression for tension pneumothorax. And the update is very important. The update is now the needle is inserted in the 5th intercostal space, just anterior to the mid-axillary line. In the 5th intercostal space, just anterior to the mid-axillary line. That is where we insert the needle now. Earlier, it was inserted in the 2nd intercostal space in the mid-clavicular line, but now it has changed. This is the triangle of safety where a chest tube is inserted, you should be able to identify this triangle. This is bounded by the lateral edge of the pectoralis major, the lateral edge of latissimus dorsi, apex is in the axilla, and the base is formed by the fifth intercostal space. Yes, in children, it is still the second intercostal space. You're right. In children, it is still the second intercostal space. It's in adults that it is changed. Very important question. This was asked in one of the recent exams, and you should be able to identify these two instruments. I even covered this in the first webinar. You know, a Eurobag is to collect urine when you connect it with the Foley's. All the measurements are present here. This one, the other one which I've labeled, is an underwater seal. The underwater seal is connected to a chest tube. And this is a special bag which is connected to the chest tube. What is so special about this underwater seal bag? You have the tube running right down till the bottom, and the lower end of the tube is submerged underwater. The lower end of the tube is submerged underwater, and the reason why we are submerging it underwater is so that air bubbles can bubble out. Air can bubble out, but air will not be sucked inside again. Right, so that air bubbles can come out, they will not be sucked inside again. That is why we call it an underwater seal. Please, yes, if bubbles are coming out, that means the chest tube is in the right position. If you can differentiate between these two images, if the difference is clear to you, please give me a thumbs up in the chat box. This is an important question for your exam. Perfect, guys. Right, this is cardiac tamponade. Cardiac tamponade is rapid accumulation of blood in the pericardial space, and you classically get a Beck's triad asked more than 10 times in the FMGE exam. Beck's triad is hypotension, raised JVP, and muffled heart sounds. Hypotension, raised JVP, and muffled heart sounds. And the emergency management is needle pericardiocentesis. This is hydropneumothorax. As compared to the previous image which I showed to you of pneumothorax. This was the image of pneumothorax where only black was there, pneumothorax was there, but here you have an air fluid level as well. So this is hydropneumothorax. If it is a hemothorax, if it is because of blood, then we put in a chest tube. So the management of hemothorax is you put in a chest tube. Diaphragmatic injuries are more common on the left side as compared to the right side. Diaphragmatic injuries are more common on the left side as compared to the right side. These are the trauma neck zones. The trauma neck zones have also been asked in the exam. You want to understand tension pneumothorax again? Okay. So cardiac tamponade, you will get hypotension, raised JVP, and muffled heart sounds. In tension pneumothorax also you have hypotension, raised JVP. To differentiate tension pneumothorax from cardiac tamponade, we will see hyper-resonant percussion note. Because यहाँ पे air है, there is air here, so you will get a hyper-resonant percussion note here. Whereas in cardiac tamponade, you will see muffled heart sounds. The emergency management of tension pneumothorax is needle insertion and then a chest tube. For cardiac tamponade, it is needle pericardiocentesis followed by thoracotomy. I hope the difference is clear between the two. Every year, one is asked in the exam. The reason why left-sided diaphragmatic injuries are more common, can anyone tell me the reason? I'll be very happy if you people can tell me the reason. The reason is because the right side is protected by the liver. Excellent, correct. Right side is protected by the liver. That is why left-sided diaphragmatic injuries are more common. Very good. These are the three trauma neck zones. Zone 1 is from the thoracic inlet to the cricoid cartilage. Zone 2 is from cricoid to angle of mandible, and zone 3 is from angle of mandible to base of skull. The questions which I want you to remember: zone 2 is the most commonly injured zone. Zone 2 is the most commonly injured zone and the most surgically accessible zone as well. Zone 2, most commonly injured and most surgically accessible. Zone 1 is associated with maximum mortality. The definitive management for cardiac tamponade: initial management is needle pericardiocentesis. The definitive management is that you do a thoracotomy, you repair the tear, and you put in a pericardial drain. Do a thoracotomy, repair the tear, put in a pericardial drain. Again, extremely important for the exam: extradural hemorrhage, subdural hemorrhage. You should be able to identify the CT scans. You should also know that NCCT, non-contrast CT scan, is the investigation of choice. Non-contrast CT scan is the investigation of choice in patients with head trauma. Extradural hemorrhage is seen in young patients following a high velocity impact, usually arterial in nature due to middle meningeal artery. This has also been asked, middle meningeal artery. You can get a lucid interval here, that is a period of normal consciousness between 2 episodes of unconsciousness. You will get a biconvex hemorrhage, which is a lens-shaped hemorrhage between the skull and the dura, and the management is to create a burr hole. Subdural hemorrhage, chronic subdural hemorrhage. So classically you see chronic subdural hemorrhage. Chronic subdural hemorrhage is seen in elderly patients following a trivial trauma. Patient is going to come with altered sensorium after a few days. This is venous in nature due to the bridging veins, and you get a concavo-convex hemorrhage here or a crescenteric hemorrhage here. You should also know about diffuse axonal injury. Diffuse axonal injury is the most severe type of primary brain injury. This occurs due to a shearing force between the gray and the white matter. And the patient will be in a state of coma, but NCCT is normal. So the classical words which you would want to read in the question would be that patient is in coma, CT is normal, and GCS is not improving. Patient in coma, GCS not improving, CT is normal. Telltale signs of diffuse axonal injury. The investigation of choice is MRI. Please remember, every year in your exam, one head injury scenario and either tension pneumothorax or cardiac tamponade are asked. So in the last 7 or 8 slides which I have shown you, minimum 2 questions are asked in your exam. Nobody should make a mistake in these points. This is the Glasgow outcome score, not the Glasgow coma. This is the Glasgow outcome score, which is a prognostic score. I want you to remember, 1 is death, 2 is a persistent vegetative state. 2 is a persistent vegetative state. Right, let me just see if you people have any questions before I continue any further. Sure, you want me to discuss SDH again? Subdural, chronic subdural hemorrhage can be seen in elderly patients following trivial trauma. EDH was being seen in young patients. EDH was being seen in young patients and high velocity impact. Subdural hematoma can occur even after a trivial trauma, right? And you can get altered sensorium after a few days to weeks. It is venous in nature. You get a concavo-convex hemorrhage. Concavo-convex, and you have to drain it out. Diffuse axonal injury, patient is in a state of coma. GCS does not improve, but the CT is absolutely normal. These will be the key words which you need to look at. Rahul, we don't do DPL. If FAST is available, diagnostic peritoneal lavage is not done. Okay. FAST is available, diagnostic peritoneal lavage is not done. We are preparing mock tests for FMGE like we did last time. Those mock tests will be made available to you before your exam. Okay, which will have clinical questions and image-based questions also. You all should know that the rule of 9 is the Wallace rule of 9. You should know palm is 1% body surface area. This is the Wallace rule of 9. You will get it in the PDF. You need to memorize the various percentages. You can be asked questions based on this. You also need to know that Lund and Browder charts are the best method to calculate body surface area burned. The Lund and Browder charts are the best method to calculate body surface area burned. This question has also been asked in your exam. Another update which I want you to know. Okay, so the extent of brain damage is more in SDH as compared to EDH. And I have already shared the important topics have already been sent to you. I can request the team to send you the list of important topics for all the subjects. And mind you, this is for FMGE. Once we send out the email tomorrow for PDFs, we will send you the list of important topics for other subjects, including surgery. You don't need to memorize the Lund and Browder charts. You don't need to memorize it. We will post the video. We will share the PDF. So let me ask relevant questions so that I can answer them. I've already told you, I'll share the video on YouTube. We will share the PDF also, okay? So the Parkland's formula is the formula for resuscitation of burns patients. It is based on ringer lactate and it is 4 into body weight into total body surface area. And you get the amount of fluid required in 24 hours. Half of this fluid is to be given in the first 8 hours and the other half is to be given in the next 16 hours. Okay, the other half is to be given in the next 16 hours. The update is the new ATLS formula. The new ATLS formula for adults, it is 2 into body weight into total body surface area. For children, it is 3 into body weight into total body surface area. So if you're asked further questions in the exam, please answer them based on the new formula until unless they specify that they want you to answer according to the Parkland's formula. Again, a very important question. This was asked in your exam as well. You should know the types of burns, the severity of burns you should be able to identify based on the image. If you see a blister, this is a telltale sign of a second-degree superficial burn. A blister is a telltale sign of second-degree superficial burn, and you should be able to identify that. If you get an image like this, where there is black charred appearance, and you can see the underlying tendon or the muscle, this is a grade 3, grade 4 burn, and grade 3, grade 4 burns are absolutely painless. Grade 3, grade 4 burns are absolutely painless, and you need to do skin grafting. The choice of fluid for burns patients is ringer lactate. First degree burns involve only the epidermis. They're red, tender, they blanch completely. One of the examples is a sunburn. They heal without scarring in 3 to 5 days. Second degree superficial burns involve the epidermis plus the papillary dermis. Blister formation is the classical finding here, which you should know about. It heals quickly without scarring. Deep burns involve the entire epidermis plus dermis. They are red, less tender. The entire area does not blanch, and they tend to form hypertrophic scars and keloids. I've already told you about 3rd and 4th degree burns. Again, a very important question asked in the FMG exam. Very important question asked in the FMG exam is autograft, isograft, allograft, and xenograft. Autograft is when you take the graft from the same person, like a skin graft. Isograft is when you take it between identical twins. Allograft is the same species, and xenograft is different species. You should know these definitions. This image of a Humvee's knife has been asked in all possible exams multiple times. All of you should know that a Humvee's knife is used for raising a split thickness skin graft. It is used for raising a split thickness skin graft. You should be able to identify a Humvee's knife. Whenever we raise a split thickness skin graft, this is a split thickness skin graft which has epidermis plus part of dermis. The most common donor site for this is the thigh. And whenever we raise a split thickness skin graft, we make cuts in that graft so as to increase the surface area. This is known as meshing of the graft. This is known as meshing of the graft. Okay, why deep burns don't blanch? That's a good question. So superficial burns will blanch, deep don't, because the vessels get thrombosed. And if the vessels get thrombosed, even when you press it, there won't be blanching. That is known as fixed capillary staining. So deep burns where the vessels are thrombosed, that is known as, it'll give rise to fixed capillary staining. These are examples of some flaps. I will tell you what all questions you need to know. These are random flaps which are not based on any named vessel. VY plasty. You have Z plasty. Z plasty is used to elongate wounds. It is used for post-burn contractures. And the ideal angle is 60 degrees, which leads to maximum elongation of 1.75 times. It is used for post-burn contractures. Post-burn contractures. A question which has been asked many times in the exam. This is a rhomboid flap which is used for pilonidal sinus surgery. Rhomboid flap which is used for pilonidal sinus surgery. Pilonidal sinus is also known as Jeep driver's disease. This question has been asked in the exam. Pilonidal sinus is Jeep driver's disease. These are axial flaps used for head and neck reconstruction, and you should know PMMC. PMMC has been asked multiple times in your exam. PMMC is pectoralis major myocutaneous flap. Pectoralis major myocutaneous flap, and this is the most commonly used flap by a head and neck surgeon. This question has been asked, most commonly used flap by a head and neck surgeon. This is Abbey slander flap used for lip and angle of mouth reconstruction. Used for lip and angle of mouth reconstruction. This was a breast cancer patient of mine where we did a latissimus dorsi flap for breast reconstruction. You should know some of the basic images for these flaps. Latissimus dorsi flap you should be able to identify. It is used for breast reconstruction. Another patient of mine where we did breast reconstruction, these two questions have been asked multiple times. The most commonly used flap for breast reconstruction is the tram flap, whereas the best flap for breast reconstruction is the DIEP flap. This one was a DIEP flap which we did for this 31-year-old lady. Somebody has asked what is the difference between a flap and a graft. Good question. Graft is a piece of tissue which does not have its own blood supply. Graft does not have its own blood supply, whereas a flap has its own blood supply. That is the difference. Graft does not have its own blood supply, whereas a flap has its own blood supply. Another one which you should know is a free fibular flap. Free fibular flap is the best flap for mandibular reconstruction. Free fibular flap is the best flap for mandibular reconstruction. Very important topic for your exam is a bed sore. This question was asked in your recent exam. This is a grade 4 bed sore because you can see the muscle. This one is a grade 4 bed sore. You should know the most common site for bed sores. The most common site for bed sores is the ischium. Ischium is the most common site for bed sores, which you should know about. Ischium is the most common site for bed sores, followed by the ischium is the most common site, followed by the greater trochanter, then the sacrum. You should know that the staging of bed sores, is the same as burns, which I've already explained to you. And for bed sores, frequent change of position is required, and you should change the position once every 2 hours. It is, Tricia is asking, random flap is not based on any blood vessel. Still, the flap has its own blood supply. Tricia, you didn't listen carefully. I said it is not based on any named blood vessel. So it does have its own blood supply, but it is not based on a named blood vessel. Okay. So you should be able to identify the grades of bed sores. If you can see the muscle, if you can see the bone, it's a grade 4 bed sore. Again, very important for your exam is a VAC dressing or negative pressure dressing. VAC or negative pressure dressing, minus 120 millimeters of mercury pressure is used. Minus 120 millimeters of mercury pressure is used. And I've listed the utility of VAC dressing here. It is used for chronic non-healing wounds, but make sure that you debride the wound before you put a VAC dressing. So images are very important for the exam. Look carefully, try to make as many notes as you can. We will share the PDF with you by tomorrow. Okay. So first we're going to start with thyroid, and common questions asked in thyroid disorders. They always ask what is the initial investigation. The initial investigation are thyroid function tests, that is T3, T4, TSH. So any patient with thyroid disorders, we will do the thyroid function test first. The investigation of choice, mind you, is fine needle aspiration cytology. So the full form has been asked, FNAC, and they've also asked what is the size of the needle used. So the size of the needle used is 23 to 30 gauge. Please remember that has also been asked in the exam. One drawback of thyroid FNAC is that it cannot differentiate between follicular adenoma versus follicular carcinoma. That differentiation cannot be done. A normal thyroid scan, the indications are when there are features of hyperthyroidism with low TSH, or you have ectopic or aberrant thyroid tissue, That is the other indication for a thyroid scan. This is a normal thyroid scan. You can see that both the lobes are shining equally, both are showing equal uptake. Let's see the abnormalities in thyroid scans, and these have been asked in all exams, FMGE, PG exams, all exams this has been asked. You can first see a non-functioning or a cold nodule. You can see that the entire gland is taking up the dye or the contrast, but there is one nodule which is not taking up any of the iodine. So that is a non-functioning or a cold nodule. A nodule not taking up the iodine is a non-functioning or a cold nodule. And mind you, cold nodules have a higher risk of malignancy. So 20% cold nodules are malignant. Whereas if you see the image below that, you can see a hot or a hyper-functioning nodule. What has happened is that only one nodule is taking up all the iodine. The rest of the gland is showing very less uptake. So that is a hyper-functioning, more uptake, and that is a hot nodule, only 4% risk of cancer. In Graves' disease, you can see there is diffuse increased uptake. It looks almost like a normal scan, but the percentage of uptake is higher. Autonomous nodule is when only one nodule is working, the other nodule is rest of the gland is completely suppressed. Now, if you have multiple hot and cold nodules, that is a toxic multinodular goiter, also known as plumber's disease. So toxic multinodular goiter is also known as plumber's disease. Another question which has been asked in your exam, that in thyroiditis, you get diffuse decreased uptake. So this thyroid scan slide is extremely important. Lots of questions have been asked. Again, to reiterate, when uptake is not there, it is a cold nodule. When you see more uptake in a single nodule, that is a hot nodule. A thyroglossal cyst, it is a remnant of the thyroglossal tract, and it usually presents as a midline neck swelling, right? Midline neck swelling. The characteristic feature of a thyroglossal cyst is that it will move both on deglutition and protrusion of the tongue. Because it is attached to the base of the tongue, even when protrusion of tongue is done, this swelling is going to move. The most common location has been asked in your exam. It is infrahyoid. And please mind you, surgery is not incision and drainage. Asked many times, it is not incision and drainage. It is Sistrunks procedure. Sistrunks procedure is when we remove the cyst along with the tract right up till the base of the tongue, and part of the hyoid bone is also removed. So entire swelling, tract right up till the base of the tongue plus part of hyoid bone. This image has been asked in your exam. So a trend this year in the exam was that they were giving a brief history and an image. So you could come to the diagnosis with either one. Now this is very clearly evident. You can see multiple nodules. So it's a multinodular goiter, right? And the surgery which is done for a multinodular goiter these days is total thyroidectomy. Total thyroidectomy. This one is a diffuse goiter. Diffuse goiters can be seen during puberty, during pregnancy, when the demand is higher, in Graves' disease, in Hashimoto's thyroiditis. These are conditions where diffuse goiter can be seen, where you can't see nodules, there is just diffuse enlargement. Again, the surgery of choice, if there's diffuse enlargement as well, would be total thyroidectomy. This sign has also been asked in the exam. This is Pemberton sign. Pemberton sign is seen in patients with retrosternal goiter, and this is seen in patients with retrosternal goiter. That means when the goiter goes behind the sternum into the mediastinum. And this sign is when you ask the patient to raise his or her hands, there will be facial congestion seen. So facial congestion is when you ask the patient to raise his or her hands. Now, mind you, a very important question which has been asked in the exam, that majority of the retrosternal goiters can be removed via which incision? Via the neck incision alone. So because majority are secondary retrosternal goiters, right? Secondary retrosternal means they start in the neck and then they go into the mediastinum. They can be removed via the neck incision. This has been asked many, many times in the exam. These are the various types of thyroid surgeries, and these descriptions of thyroid surgeries have been given in Bailey, and you should know about them. These descriptions you should remember. So hemithyroidectomy is the minimum surgery for thyroid, and mind you, hemi is lobectomy plus isthmusectomy, right? Total thyroidectomy is when you remove the entire gland. Subtotal is when I remove majority of the gland, but on both the sides, I will leave some amount of thyroid tissue, right? That is subtotal thyroidectomy. Near total thyroidectomy is when one entire lobe, the isthmus, is removed, majority of the other lobe is removed, only some amount of tissue is left on the other side. So that is a near total thyroidectomy, also known as a Hartley-Dunhill procedure. Okay, so these are the four thyroid surgeries. Minimum surgery is hemithyroidectomy. You should also know that the incision used is the collar incision, right? The collar incision, which is 2 finger breadths above the suprasternal notch. So collar incision, which is 2 finger breadths above the suprasternal notch. This instrument, and I'll be talking about a lot of instruments today. I'll show you a lot of slides of instruments. This is a Joel's thyroid retractor, which is used during thyroid surgery. And another question which has been asked in the PG exam is that how many Joel's retractors are required? So you need one on each side. So two Joel's retractors are required during thyroid surgery. This is also an important slide. This is minimally invasive video assisted thyroid surgery. Minimally invasive video assisted thyroid surgery. The same can be used for parathyroid as well, right? And the most common approach you can see here, it is almost like doing laparoscopy for the thyroid gland. And the most common approach is the transaxillary approach. You go via the axilla. So it's a transaxillary approach, which is preferred here. So I have already told you, don't worry. All those who have registered, who are listening to the session, will be getting the PDFs tomorrow on your registered ID. So try to make notes. Try to write down the important points. Otherwise, all these slides, the PDF, you will be getting tomorrow. Okay. So try to understand, try to remember the concept. That is more important. You can always brush through the slides once more when you get the PDF. Okay. These two signs, many times in the FMGE PG exam, they've been asked. These are signs of hypocalcemia. Trousseau sign is a carpopedal spasm. When you inflate the BP cuff, the hand goes in spasm. This is carpopedal spasm. And a question which has been asked in the FMG exam is, this is also known as obstetrician's hand deformity. If you've taken a delivery in the labor room, you'll know why this is known as obstetrician's hand deformity. So obstetrician's hand deformity. Schwastig sign is if you tap over the facial nerve, there will be facial spasm. And both are severe signs of hypocalcemia, which can be seen after thyroid surgery. This is exophthalmos, which is commonly associated with Graves' disease. This is an eye sign associated with Graves' disease. You should be able, this is a spotter, you should be able to pick up this image easily. This was one of the questions which was asked in the FMG exam, and I thought it was a very good question in the last FMG exam, where they had asked that these type of skin lesions are seen with hypothyroidism or hyperthyroidism. So more common in which one? Now, students sometimes get confused because this condition is known as pretibial myxedema. Now, myxedema, you start associating it with hypothyroidism, but in reality, this is more common with hyperthyroidism or Graves' disease. So, more common with hyperthyroidism or Graves' disease, pretibial myxedema. These slides have been asked umpteen number of times in all possible exams. This is papillary carcinoma thyroid, which is the most common thyroid cancer. The risk factor is radiation exposure. Diagnosis is by FNAC. And the classical histopathological features of papillary carcinoma thyroid, you will get orphan aniide nuclei, right? Orphan aniide nuclei, which are clear nuclei, samoma bodies, which are foci of dystrophic calcification. So these bluish bodies, which you can see here, which I've marked as well, these are samoma bodies, which are foci of dystrophic calcification. And you can see intranuclear inclusions as well. Another common question asked in pathology is, where else or in which other tumors do you see samoma bodies? So samoma bodies can also be seen in serous cystadenocarcinoma of the ovary, papillary renal cell carcinoma, meningiomas. These are some other tumors where you can see samoma bodies as well. Follicular carcinoma is the second most common thyroid cancer. Long-standing multinodular goiter is a risk factor. So very important clinical scenario for your exam. Patient with long-standing multinodular goiter shows sudden increase in size. Now, a lot of students, because of the sudden increase in size word, they get confused with anaplastic carcinoma. No, if there is a multinodular goiter and sudden increase in size, it's more likely to be a follicular carcinoma. Okay. Anaplastic carcinoma, the age group is different. It would be seen in the fifth or the sixth decade of life. I have told you that FNAC cannot differentiate between adenoma versus carcinoma. So the minimum surgery in such a patient will be hemithyroidectomy, and that's how we will come to the diagnosis. Medullary carcinoma thyroid. This arises from the parafollicular or C cells. These cells are the ones which secrete calcitonin, and it can either be sporadic or familial. And the typical clinical scenario which you will get is a patient with the thyroid swelling. FNAC is done, and FNAC reveals a myeloid rich stroma. So these are the key words which you need to listen to. And please remember that in your exam now, whether it is FMGE or PG exam, always focus on these key words. If you can identify these key words, you can quickly reach to the correct answer. So a myeloid-rich stroma, this pinkish material which you can see, is classical of medullary carcinoma thyroid, which can either be sporadic or familial. The familial one is seen in MEN2 syndrome. So those were the slides in thyroid disorders, the images which I want you to know. Moving on to oral carcinoma, which is also a very important and a frequently asked topic in the FMG exam. So you should be able to differentiate between candidiasis and leukoplakia. If you can see the above image, candidiasis, you can see a hyperemic border. You can see this reddish border. And candidal patches can be rubbed off. You can rub them off. Leukoplakic patches are white patches which cannot be rubbed off. You can see here this white patch which cannot be rubbed off, and it increases the risk of cancer by 3 to 6 times. This is erythroplakia, and erythroplakia is a red patch. This one is a proliferative varicose erythroplakia. It increases the risk of cancer by 6 to 9 times. Again, like leukoplakia, erythroplakia also cannot be rubbed off. This is oral submucous fibrosis, which is a hypersensitivity reaction to products of betel nut. So betel nut or areca nut can cause fibrosis, because of which the patient cannot open his mouth completely, right? There is restriction in mouth opening. That leads to poor hygiene and increases the risk of oral carcinomas. A very common mistake made by students, they think that if it is fibrosis, if you cut the fibrous tissue, patient will have mouth opening. But if you cut the tissue, how will the body heal? The body will heal with more fibrosis. So the treatment of choice here is intralesional steroids or intralesional triamcinolone. Please remember this. This question has also been asked many times. Plummer-Vinson syndrome, also known as Patterson-Kelly-Brown syndrome, has also been asked many, many times in the exam. Plummer-Vinson or Patterson-Kelly-Brown. You can see that patients will usually have iron deficiency anemia, angular stomatitis or glossitis, and dysphagia due to post-cricoid webs. This condition is more common in perimenopausal women, and it increases the risk of hypopharyngeal cancer and squamous cell carcinoma of the esophagus. So the two cancers where there's increased risk with this condition are hypopharyngeal cancer and squamous cell carcinoma of the esophagus. This has also been asked in the exam. These two one-liners and this image has been asked many times. The most common site of oral cancer all over the world is the lateral border of tongue. The most common site in India is the gingivo-buccal sulcus or the buccal mucosa. That is the most common site. The biopsy, we always take an incisional biopsy in these cases from the edge. So we will take an edge or a wedge biopsy to confirm the diagnosis. Edge or a wedge biopsy is taken. Neck dissection, the incision name has been asked in the exam. This is modified Schubinger's incision, which is used for neck dissection. This has been asked many times. This is a summary of neck dissection. Again, there were questions from neck dissection in the PG exam. There were questions in the FMGE exam as well. So you should know about neck dissection. So radical neck dissection was described by Kreil, was the surgeon who described radical neck dissection. Level 1 to level 5 lymph nodes in the neck are removed. Level 1 to level 5 lymph nodes are removed, plus 3 extra lymphatic structures. The 3 extra lymphatic structures which are removed are sternocleidomastoid, internal jugular vein, and spinal accessory nerve. In addition to this, the tail of parotid and the submandibular gland is also removed. Modified radical neck dissection, the incision used is Schubinger's incision, and level 1 to level 5 lymph nodes are removed, but we save at least 1 extra lymphatic structure. If you save 1, then it is known as MRND1. If you save 2, it is MRND2. If all 3 are saved, we call it functional neck dissection. That is, if you're saving spinal accessory nerve, internal jugular vein, and sternocleidomastoid, all 3. Selective neck dissection is when you're removing selective lymph nodes. Central neck dissection is when level 6 lymph nodes are removed. Supraomohyoid is level 1, 2, 3, and extended supraomohyoid is 1, 2, 3, and 4. Again, I've told you that I will be taking questions at the end. I don't want to miss out on these images. First, let me cover the images. Then I'll answer your academic questions. And then if you have any general queries, I'm reiterating the PDF will be shared with you. Try to make notes. Not everything is written on the slides. Just write down things. Images you will get by tomorrow. This flap has been asked in all possible exams. It is very, very important. This is the most commonly used flap for head and neck reconstruction. This is pectoralis major myocutaneous flap. Pectoralis major myocutaneous flap. That means we are going to rotate the pectoralis major and we will cover the defect which is caused after oral cancer surgery. This is a ranula. Ranula image was there this time in the FMG exam also. At least 10 times previously also ranula has been asked in the exam. Ranula is a mucus extravasation cyst involving the sublingual gland. It is fluctuant and brilliantly transilluminant. Incision and drainage should not be done. Mind you, no incision and drainage. Marsupialization or excision can be done along with the sublingual gland. A plunging ranula is a mucus retention cyst involving the sublingual and the submandibular gland. There is a swelling in the oral cavity and a swelling in the neck, and the management is excision of the intraoral swelling, the sublingual gland, and aspiration of the neck swelling. This is another new table in Bailey. This is a Staphne bone cyst, which is the most common site of ectopic salivary tissue. Most common site of ectopic salivary tissue. Again, salivary glands is a very important topic for the FMG exam. At least one clinical scenario is definitely asked. And there were some very good questions asked from salivary glands. Some were so difficult that even postgraduate aspirants could not answer them. So parotid abscess, will present as a painful parotid swelling. Fluctuation is a late sign, and the management is incision and drainage. While draining such an abscess, we should be careful that we don't injure the facial nerve. Silolithiasis, that is stone formation, the most common composition is calcium phosphate, and submandibular gland is more commonly affected than the parotid gland. Submandibular gland is more commonly affected than the parotid gland. And a question which has been asked in many exams, investigation of choice is NCCT, non-contrast CT scan. Okay, mind you, non-contrast CT scan is the investigation of choice at three places: salivary gland stones, head injury, and renal stones. So don't forget these three. All three have been asked: head injury, salivary gland stones, and renal stones. A parotid swelling typically will lift the ear lobule. And a beautiful question asked in the FMGE exam was that how do we clinically know that there is deep lobe involvement? So we clinically know whether the deep lobe is involved or not. You just need to ask the patient to open his or her mouth, and you will see that the tonsillar fossa is pushed medially. If the tonsillar fossa is pushed medially, that signifies that the deep lobe is involved. The tonsillar fossa pushed medially signifies that the deep lobe is involved. Okay. It won't be possible for me to give the voice recording. That is not possible. But the slides, whatever is written on them, I will try to add some extra points as well that we will definitely share with you. Okay. The most common tumor of parotid gland is pleomorphic adenoma. Investigation of choice is FNAC, that is fine needle aspiration cytology. I've already told you 23 to 30 gauge needle is used. And the minimum surgery for parotid gland is superficial parotidectomy. So you should know this clinical examination point. It has been asked in the exam. This incision has been asked very commonly, and a very common question which is now being asked is regarding nerve injuries for various surgeries. So today I'll be talking about head and neck surgeries and breast surgery. What are the potential nerve injuries? That is not only an important question for FMG, but also for the PG exams. The incision used is a lazy S incision. This has been asked. It is also known as a modified Blair's incision. The nerve injuries associated with parotid gland can be marginal mandibular nerve injury. This was there in one of the exams this year. This is going to give rise to drooping of the angle of mouth. So I'm sure you must have heard one of these three gentlemen speaking: Sylvester Stallone, Jeffrey Boycott, or Sharad Pawar. All three of them, when they speak, there is drooping of the angle of the mouth. And that is because this nerve, marginal mandibular nerve, has been injured in them. Anesthesia over the beard area. So there was a clinical scenario given last year that a person shaves after undergoing parotid surgery but cannot feel any sensation there. This is because of the greater auricular nerve. And the nerve implicated in Fraze syndrome or gustatory sweating. Gustatory sweating is after parotid surgery, when the patient eats food, there is sweating over the parotid region. That is Fraze syndrome or gustatory sweating. And the nerve implicated is the auriculotemporal nerve. So one out of these three is definitely there in all the exams. You should know about these nerve injuries. Submandibular gland, the question which was asked, a beautiful question which was asked in your exam. A beautiful question which was asked in the exam was how to differentiate gland enlargement from lymph node enlargement, because you can even have lymph nodes in the submandibular region. So we carry out bimanual palpation. Again, very important question for the exam. Cystic hygroma or lymphangioma, this was asked in the PG exam. Also in the FMG exam, it has been asked. The most common site is the posterior triangle of the neck. That is the most common site for this lesion. It is a fluctuant lesion, compressible swelling, brilliantly transilluminant. So if you shine a torch, it will shine brightly. You should also know about the other brilliantly transilluminant swellings in the body. Ranula, I told you, is transilluminant. Meningeocele is transilluminant. Hydrocele is also transilluminant. So these are some other swellings where brilliant transillumination can be seen. Investigation of choice in such a child is FNAC, and the management is aspiration and sclerotherapy, followed by surgery. Another question which is slightly difficult, but you should know about it. Another question which has been asked in the exam is that if you're doing surgery for a cystic hygroma, then the spinal accessory nerve can be injured. Then the spinal accessory nerve can be injured. The other brilliantly transilluminant swellings which I told you were hydrocele, meningeocele, and ranula. Cervical lymphadenopathy, this is a constant question. Every alternate year this is asked. Most common pathological cause in India is tuberculosis. And you will get a collar stud abscess, right? It's a collar stud or a cold abscess. Mind you, you always carry out anti-gravity aspiration. Never aspirate it via the dependent route. Always anti-gravity aspiration should be done, because if you go via the dependent route, it can lead to a sinus formation. Lipoma, it is the most common swelling which can occur in the body. You can get a slip sign. Management is excision. In one of the PG exams, they asked this year that lipoma in which region of the body increases the risk of sarcomatous change or malignant change, and the answer is retroperitoneal. So lipomas which are there in the retroperitoneum can develop into sarcomas later on. So please remember that point as well, retroperitoneum. The image of dermoid cysts has also been asked in all possible exams. These are cysts which are formed at the line of embryonic fusion. They are again fluctuant. Diagnosis can be by FNAC. The most common site is the outer canthus of the eye. You can see the boy with a swelling around the outer canthus of the eye. Another common site is retroauricular, but the most common is the outer canthus of the eye, and the management is excision. But before excision, always rule out intracranial extension by doing a scan. Implantation dermoid can occur after ear piercing, or if somebody gets hit by a thorn, that can form a dermoid there. That is known as implantation dermoid. This swelling was asked last time in the FMG exam, even in the PG exams, it's been asked multiple times. A sebaceous cyst is a blocked hair follicle duct. The classical finding in a sebaceous cyst is a punctum. And this is the punctum which you should look for, and that clinches the diagnosis. This is an infected sebaceous cyst. For both, the management is excision. Multiple sebaceous cysts can be seen in the scrotum or the scalp. Those are the sites for multiple sebaceous cysts. Another question which has been asked in your exam, sites where sebaceous cysts will not be seen. So wherever hair are not there, sebaceous cysts will not be seen. So palm and sole, you will not get sebaceous cysts. Carbuncle is common in diabetic patients, and the classical area is the nape of the neck, behind the neck. That is the classical area. You can have multiple pus oozing points and we need to carry out drainage. The question which has been asked in the exam, what incision is made? We make a cruciate incision to drain a carbuncle. Degloving injury was a question few years back in the PG exam, and whatever questions are asked in the PG or the UPSC exam are sometimes asked in your FMGE exam as well, which is why I have covered the UPSC exam paper for last year. It is there on my YouTube channel. I've also covered the last few years FMGE papers on my YouTube channel. Make sure that you watch those YouTube videos before you go for your exam, because sometimes you can get at least 10 to 15% repeat questions as well. So a degloving injury is when the skin and subcutaneous tissue is stripped of the fascia. That is a degloving injury. Cellulitis can be caused by streptococcal or staphylococcal infection, and the management of cellulitis is antibiotics, limb elevation, and magnesium sulfate dressing. Fournier's gangrene has also been asked in the exam. This is necrotizing fasciitis of the perineal region. It is caused by aerobic plus anaerobic organisms, and it is rapidly progressive. It is seen in immunocompromised patients, and the management is aggressive debridement. Even after aggressive debridement, there can be high mortality in these patients. Another question, slightly difficult, but you should know about it, that two structures which are not involved or not affected by Fournier's gangrene are the testis and the urethra. So no matter how severe the infection, the testis and the urethra are usually spared. So these were the slides for oral cancer, salivary glands, and common neck swellings. Now we move on to slides which are related to breast disorders. And invariably in your exam, there are 2 to 3 questions related to breast disorders. So triple assessment for a patient with a breast lump. That means 3 things have to be done: history and physical examination. Then radiological tests are done. For patients who are less than 40 years of age, we will carry out an ultrasound. More than 40 years of age, we do a mammogram. The reason for this is that young patients have dense breast tissue. So young patients have dense breast tissue, and mammography is not sensitive in them, which is why for less than 40, we will carry out an ultrasound. Please make sure that this point is clear, because it's been asked many times in your exam. Histopathological tests, the investigation of choice for breast disorders is not FNAC. It is not FNAC. It is a true cut biopsy, and I'll talk about true cut biopsies in some time. This is the BIRADS score. BIRADS has been asked in your exam, even in the PG exam. It stands for Breast Imaging, Reporting and Data Systems. BIRADS is breast imaging, reporting and data systems. It divides the reporting of any of the mammogram, ultrasound or MRI into 0 to 6. 0 is an incomplete scan. Incomplete scan means the radiologist cannot see anything. And what advice will such a radiologist give? The advice given would be do some other imaging test. So supposing a patient has had a mammogram, but nothing can be seen, we will do an alternate imaging test like ultrasound or MRI if the score is BIRADS 0. Alternate additional imaging tests. BIRADS 1 is negative, everything is fine. You tell the patient to come back after 1 year. Routine screening is after 1 year. BIRADS 2 is benign. Again, you tell the patient to come back after 1 year. Okay. BIRADS 3 is probably benign. Probably benign was asked last year in the exam. Short-term follow-up. That means you will repeat the scan instead of 1 year, you will repeat it after 6 months. BIRADS 4 is a suspicious lesion. All suspicious lesions should be biopsied. all BIRADS 4 lesions should be biopsied. Okay. BIRADS 5, also lesions high risk of malignancy, they should also be biopsied. And BIRADS 6 is a biopsy proven malignancy. So this is the BIRADS score. You should know about this. For breast examination, the best technique is the dial clock method. I've ticked there. That is why you would notice that whenever we report a breast lump, we always write 6 o'clock, 8 o'clock, 10 o'clock. So that is the dial clock method of depicting a breast lump. The biopsy techniques, you can have punch biopsy. This is a punch biopsy instrument. It is used for skin lesions. Skin lesions like Paget's disease, like skin cancers. You can use a skin biopsy or a punch biopsy for sepsis or punch biopsy instrument. True cut or core needle biopsy, you can see a true cut or core needle biopsy gun. This is the investigation of choice at 3 places: for breast lumps, for prostate, and for soft tissue sarcomas. All 3 have been asked in the exam. You should also know that this true cut biopsy, which is the investigation of choice for a breast lump, a 16 gauge needle is the best size for a breast biopsy. So 16 gauge is used for breast lesions. These 2 clinical signs, many times they've been asked. Dimpling of the skin is because of attachment of ligaments of Cooper. Sorry. So these are the 3 places where true cut biopsy is done, and 16 gauge needle is the best for breast biopsy. These 2 clinical signs have been asked many times in the exam. Dimpling of the skin, you can see a dimple on the skin. This is due to involvement of ligaments of Cooper. Whereas nipple, if it is pulled inside, that is due to lactiferous duct involvement, right? Retraction of nipple is due to lactiferous duct involvement. Both these signs don't denote skin involvement. Please remember this. These signs don't denote skin involvement in breast cancer. Okay. So make sure you remember that point. It is not a sign of skin involvement in breast cancer. Maximum number of times this clinical sign has been asked. This is peau d'orange or orange peel appearance, where the skin appears thickened and like an orange peel. This is due to blockade of subdermal lymphatics, right? This has been asked many times, blockade of subdermal lymphatics. And if this is present in cancer, it is a sign of skin involvement. It is a sign of skin involvement in cancer. For mammography, there are 2 views which are done. For mammography, there are 2 views which are done. You have craniocaudal and you have mediolateral oblique. 2 views are taken. Please remember that mammography is the best screening modality for breast cancer. It is not breast self-examination. Mammography is the best screening modality for breast cancer, not breast self-examination. You can get popcorn calcification in patients with a fibroadenoma, that is a benign lesion, also known as a breast mouse. It is mobile, right? I'll talk about that in the next few slides. In a malignant patient, you have spiculated margins and microcalcifications, spiculated margins and microcalcifications. This is a mediolateral oblique view, MLO, and this is where you will see maximum tissue. This is where you will see maximum tissue. Also, you can see here the axilla is also visualized. The axilla is also visualized in the MLO view. This is the molecular classification of breast cancer. 2 or 3 questions have been asked in your FMGE exam. Lots of questions have been asked in the PG exam from the molecular classification. So it is based on gene expression profiling. Based on gene expression profiling. You should know about luminal A cancer. Luminal A is ER/PR positive. ER/PR are estrogen and progesterone receptors. ER and PR are estrogen and progesterone receptors, which can be seen in breast cancer patients. So if ER and PR, that is estrogen and progesterone receptors, are positive, we call it luminal A. It has the best prognosis and it is the most common. HER2/neu, which is another membranous receptor, is negative in these patients. Basal type is triple negative. All three are negative, ER/PR negative, HER2/neu negative. This is the most aggressive and has the worst prognosis. So these are the two types for the FMG exam. This much is enough. These are the boundaries of axillary clearance. This was a case of mine where I'd done an axillary clearance. I've highlighted the boundaries. Axillary vein is superior. Thoracodorsal pedicle is lateral. Angular vein is inferior. And Halsted ligament is medial. Mind you, long thoracic nerve I've depicted here, but it is not a boundary of axillary clearance. Okay, it is not a boundary of axillary clearance. These are the boundaries which you should know for the exam. Thoracodorsal pedicle supplies the latissimus dorsi muscle. Very important image. It has been asked in your exam. This time in the FMG exam, this question was there. Patient undergoes a mastectomy and comes with this deformity. This is winging of scapula. You can see that the scapular border has become more prominent, and this is due to injury to which nerve? Long thoracic nerve. So don't forget this. This is an important image. Other nerves which can be injured in breast surgery, the most commonly injured is intercostobrachial nerve, ICBN, which is the sensory nerve to the inner aspect of the upper arm. So how will the patient present? The patient will complain of anesthesia in the region of the axilla. There'll be anesthesia in the region of the axilla. Long thoracic nerve, I've already told you, gives rise to winging of scapula. Thoracodorsal nerve supplies the latissimus dorsi, and the lateral and medial pectoral nerves supply the pectoralis major and minor. This also you should be able to identify. This is lymphedema of the upper limb. You can even have lymphedema of the lower limb. This is lymphedema of the upper limb, and post-mastectomy lymphedema is the most common cause of upper limb lymphedema. So post-mastectomy lymphedema, that is after breast surgery, that is the most common cause of upper limb lymphedema. You all know that the most common cause of lower limb lymphedema is filariasis. Right, correct. So it is filariasis that is the most common cause of lower limb lymphedema. This is another very important question which has been asked in the exam. Patients with long-standing lymphedema, can develop secondary malignancy, and the secondary malignancy is known as angiosarcoma. This angiosarcoma will present as bluish or reddish nodules. You can see here these bluish or reddish nodules. And this syndrome is known as Stewart-Treves syndrome. Okay. So I hope all of you are following me. If you're following me, just give me a thumbs up in the chat box. Again, to reiterate, those who've joined in late, the PDF will be shared with you of all the images and whatever is written on the slides. Having said that, please try to jot down the important things which I'm saying, as they would be helpful for your exams. This is part 1 of surgery images. We will at least have 1 or 2 more sessions in which I'll cover the other portions as well. Right. Okay. So thank you for giving me a thumbs up in the chat box. Moving forward, I hope you're still able to hear me. So local recurrence after breast cancer, can be seen, and this is how local recurrence is going to look like after breast cancer. I hope all of you can see me now. You can see the slides, please. Okay, perfect. Sorry for the glitch. So this is local recurrence after breast cancer, and local recurrence can either come as a mass, or you can see that there can be multiple small skin lesions. This is known as cancer en cuirasse, when the cancer encases the chest wall, and we can detect local recurrence. The best investigation is MRI. Sentinel lymph node biopsy was asked this year also, last year also. It is the first draining lymph node from the cancer, and this is the blue dye technique. This was a case of mine where you could see the dye coming in the lymphatics and staining these lymph nodes. So whichever lymph nodes stain blue in color, they are the sentinel or the first draining lymph nodes. And the dye which we use, this has been asked in the exam, this is methylene blue. Another way of carrying out sentinel lymph node biopsy is using a technetium-99 sulfur colloid. Yes, isosulfan blue can also be used, methylene blue or isosulfan blue, either one can be used. That is correct. So another technique of carrying out sentinel lymph node biopsy is technetium-99 tagged sulfur colloid. That is, we inject this radioactive compound, and this gamma camera has been asked in the exam, the image. This gamma camera detects radioactivity. So whichever lymph node is the hot lymph node showing maximum radioactivity, that will be the sentinel lymph node. Mind you, the best technique for sentinel lymph node biopsy is the combination technique, blue dye plus radionuclide. This flap marking has also been asked. This is the latissimus dorsi flap. Which is based on the thoracodorsal pedicle. Yes, sentinel lymph node biopsy. Some of you have seen my videos. You remember the Chernobyl example which I've given you. Yes, that is the same. So this is a flap for breast reconstruction. This is the latissimus dorsi flap. This was a patient of mine where we done this reconstruction. We take it from the back, we swing the muscle forward, and we reconstruct the breast. But the questions which have been asked, the best flap for breast reconstruction is the DIEP flap. This was again a patient of mine where we did a DIEP flap. This question has also been asked in the exam. DIEP flap is deep inferior epigastric artery perforator flap. That is the best flap for breast reconstruction. Chemoport was asked last year in the exam. Chemoport is how we give chemotherapy. So this port is put below the clavicle here, and we just access the port and we can give chemotherapy freely in a central vein. This is a chemoport. You should be able to identify this. It is used for delivering chemotherapy. Now, these images are very, very important. Two such images, one was there in your mid-year exam, one was there in the December exam of FMGE. Breast abscess, you will see in lactating mothers. Staphylococcus aureus is the organism. Oropharynx of the child is implicated. Clinical features, you will have pain, swelling in a lactating mother. There will be fever. You can see a reddish swelling like this. And the management is antibiotics. If pus is there, you need to aspirate. If that also fails, you will do incision and drainage. Again, for incision and drainage, we use a number 11 blade, which I will show you later. That has also been asked in your exam. Breast abscess image and clinical scenario, you all should be able to identify. This was asked in one of the PG exams. This, they had shown that it was a non-lactating mother, non-lactating lady, and she had more than 1/3 area of Peau d'Orange. I told you, Peau d'Orange can be seen because of blockade of subdermal lymphatics. And if more than 1/3 area of PDO is there, that is a sign of inflammatory breast cancer. So I hope you can differentiate between the two. This was an abscess. It will be typically seen in lactating mothers, right? Whereas this one, non-lactating, it is inflammatory breast carcinoma, and this is T4D. Paget's disease has also been asked many, many times. Paget's disease starts off as an itchy lesion, and you can see that the nipple areola, NAC, is nipple areola complex. You can see that the nipple areola complex is completely destroyed. The nipple areola complex has been completely destroyed. Diagnosis is by a punch biopsy. Diagnosis will be by a punch biopsy. You will see Paget cells in the epidermis, and the management of Paget's disease is the management of the underlying lump. Mondor's disease was also there in your exam, in the mid-year exam. Mondor's disease is thrombophlebitis of the chest veins. And the most commonly involved vein is the lateral thoracic vein. The most commonly involved vein is the lateral thoracic vein, that is Mondor's disease. Again, these two images have also been asked. Gynecomastia is enlargement of the male breast. You can see here both the sides are involved, and it is diffuse enlargement of the male breast. Whereas this was a patient of mine who had male breast cancer. You can see a hard lump here. That it is not gynecomastia, it is a hard lump. So you should be able to differentiate gynecomastia from male breast cancer on images. Again, I'm repeating these images for breast and thyroid disorders. Every time in the FMG exam, there are 2 to 3 questions, so you should know about them. So that takes care of breast, thyroid, oral cavity, salivary glands. Now I'll be showing you common instruments. At least 2 instrument-based questions are also asked in your exam. So I'm going to show you these instruments. You'll get the PDF where all this would be written. A Rampli sponge holder is used for holding a sponge to clean the area. You can see it has a fenestrated end and there are serrations. So the blades are fenestrated and it has serrations as well. These are towel clips. These are 2 types of towel clips. All this is important for the PG exam as well. You have the Mayo clip and you have the Doyen's clip. Both are used for holding linen or holding. Sometimes you would have seen that the cautery is fixed using towel clips. Very important for the exam, this is a BP handle, barred Parker handle, barred Parker handle, and on this barred Parker handle goes the blades. So these are the surgical blades. You put the blades on the barred Parker handle. Blades, the questions which have been asked many times. Number 11 is the stab blade. It is used for incision and drainage. This is pointed. This is a stab blade used for incision and drainage. Number 12 blade is curved. Number 12 blade is curved, and this is for suture removal. This is used for suture removal. All the other blades, that is 10, 15, 20, 21, 22, and 23, all of these are used for making incisions. All these blades are used for making incisions. This is a suction cannula used for sucking out blood or collection whenever you're operating. It is a suction cannula, also known as a Yankauer suction cannula. These are skin hooks. Skin hooks are used for breast surgery to raise the flaps or for thyroid surgery to raise the flaps. You can have a single hook or double hook skin hooks. Cat's paw retractor. This is used for retracting superficial tissue. And you can see here that one of the ends is shaped like a cat's paw, which is why the name cat's paw retractor. This retractor, the surgeon or the assistant has to hold themselves, or the nurse has to hold. So this is a non-self-retaining retractor. It won't remain in place by itself. Somebody has to hold it. Zernies also has to be held by somebody. Zernies retractor, solid blade at one side, fenestrated blade on the other side. Solid at one side, fenestrated at the other side. again for superficial structure retraction, used for retracting superficial structures. Langenbach is just one solid blade at right angles for retraction. This can be used for open cholecystectomy. Langenbach retractor can be used for open cholecystectomy. Morris retractor, you can see Langenbach, I'll show you again. Langenbach had a narrower blade. Morris has a wider blade and a bigger blade. Again, it can be used for abdominal surgeries. I use it for mastectomies. When I'm doing an MRM, we use a Morris retractor as well there. Devers is a question mark shaped retractor. Question mark shaped retractor used for abdominal surgery. That is a Devers retractor for abdominal surgeries. Devers has been asked many times in all exams. Doyen's retractor can be used to retract the bladder. This is a Doyen's retractor. It is more curved, has a broader blade as compared to a Devers retractor. Now, all those which I had shown you previously were non-self-retaining retractors. They won't remain in place themselves. Mastoid retractor is a self-retaining retractor. It has a lock. When you put it in place, it will remain there. So you don't need an assistant to hold this retractor. It will remain in place by itself. This is a Balfour self-retaining retractor used for abdominal surgeries. These two blades will retract the abdominal wall. These are used for abdominal wall retraction, whereas this one will retract the bladder, whereas this Doyen's will retract the bladder. So this is a Balfour self-retaining retractor. This is a Book-Walter self-retaining retractor where you can put this ring and multiple such retractors can just be put in place. This is a Book-Walter retractor. So all these retractors are important for your exams. This one is a self-retaining retractor. Joel's, I've already told you, you need two Joel's retractors, one on each side for thyroid surgery. Needle holder, you will have crisscross serrations. You can see here, there are crisscross serrations and there is a groove as well. There is a groove and there are crisscross serrations so that the needle does not slip out. So that the needle does not slip out. This is a needle holder. Whereas in an artery forceps, you will just have transverse serrations. Here you can have crisscross serrations, and that's how you differentiate. Yes, somebody is asking, Joel's retractor is self-retaining. Joel's will remain in place by itself. It is self-retaining. So you should be able to identify a needle holder. This is tooth forceps. You can see teeth here. So for holding tough structures, you can use tooth forceps. This is a plain forceps. It does not have teeth, so it will not be traumatic. It does not have teeth, so it will not cause damage. It will not cause damage to delicate structures. Whereas if you hold with teeth, it will cause damage to delicate structures. This is plain or non-toothed forceps. For holding vessels, we use a DeBakey's vascular forceps. So DeBakey's vascular forceps will have a horizontal groove like this, and it will have transverse serrations. It will have transverse serrations and a horizontal groove. This is a DeBakey's vascular forceps. Russian forceps is what I use for holding lymph nodes. So you can see that it has multiple small teeth. This is a Russian forceps used for holding lymph nodes. This is a Mayo or a heavy scissors. This is a straight Mayo scissors, which is used for cutting tough structures, used for cutting tissue, used for cutting sutures. I'm sorry. This is a Mayo scissors used for cutting drains as well. Straight scissors. Metzenbaum is curved. Mayo was straight. Metzenbaum is curved. And this is for tissue dissection. This one is for tissue dissection. So this is a tissue scissors for tissue dissection. This is Metzenbaum. Makindo is even finer tissue is Makindo scissors. Very important instruments now. Last 10 minutes is where you will definitely get 2 or 3 questions in your exam. So this is a Varies needle used for creating pneumoperitoneum. Everyone should be able to identify a Varies needle asked at least 10 to 20 times for pneumoperitoneum, okay, during laparoscopy. Once you insert this, then you can push in gas, that is carbon dioxide, through this. This is a sharp laparoscopic trocar. You can see this is sharp, right? This one is a sharp laparoscopic trocar. But you can have a blunt trocar as well. And if you use a blunt trocar, that is known as a Hassan's trocar. Hassan's, you can see, is blunt. Previous one was sharp. This is blunt. All these are used for laparoscopic surgery. These are laparoscopic instruments. Laparoscopic instruments are long black instruments. The black coating around the instrument is insulation. The black coating is insulation so that current does not leak out. The black coating is insulation so that current does not leak out. This has also been asked. This is SIL, single incision laparoscopic surgery port, where through one port you can put in 3 instruments and you can carry out surgery using a single incision. Very important for your exam is robotic surgery, and this is the Da Vinci robotic system which is being used these days. This question has also been asked in your exam. The Da Vinci robotic system is being used. Humby's knife, at least 20 times in the exam this has been asked. Humby's knife is so this is a Da Vinci robotic system for robotic surgery. And this is the system, robotic system, which we are using. You should remember the name Da Vinci robotic system. Humby's knife has been asked at least 20 times in the exam. It is used for raising skin grafts. This is a Humby's knife. It was asked last year as well. You people should be able to identify it.